Okay, welcome back. As you know, PTAC will issue a report to the Secretary of Health and Human Services that will describe our key findings from the public meeting on encouraging rural participation in population-based total cost of care models. We'll now take some time for the committee to reflect on what we've learned from our sessions today. We'll hear from more experts tomorrow, but want to take some time today to gather our thoughts before adjourning for the day. Committee members, I'm going to ask you to find the potential topics for deliberation document is tucked in the left front pocket of your binder. To indicate that you have a comment, please flip your name tent. I'm going to ask who would like to start, and I'm probably going to go around the table and ask people for their input. So, no volunteers yet, so I'll ask Jay, what are your thoughts of today?
A lot of thoughts for today, but obviously I think the overwhelming theme is, the requirement for capital investment for infrastructure, team-based care, and primary care, and everything that encompasses, not just primary care physicians. I think the other aspect, which we heard but we didn't spend a lot of time on, is the fact that rural communities are ecosystems, and primary care doesn't exist in a vacuum. And as well as we have to ensure the survival of primary care physicians and team-based care, we've got to ensure the survival of rural hospitals. Not necessarily meaning they need to be 50 or 100 beds and inpatient. And I think just, what is a hospital in a rural setting in today's world? Maybe, it's critical access, it's an rural emergency hospital, whatever it is. Maybe it's a micro hospital, with 5 or 10 beds, but they're economic engines for these rural communities. It's very difficult to recruit a primary care physician without a hospital. You sure is not going to recruit specialists without a hospital. And a hospital takes on a healthcare center, whatever, outpatient services, surgical services, whatever they may be. But somehow we need to work that into this report because one cannot exist without the other. And if we lose another 100 to 150 rural hospitals this year, we're going to even have bigger problems with rural healthcare. So we need to work that in some way to the report.
Jim?
I agree with those comments, and there are a couple things that I took away. The first dovetails a little bit on Jay's comment. I was struck by, in our first panel, the comment around aligning incentives in the rural communities is that one singular focus could be keeping the community healthy. And in order to do that, it's preserving access to acute, potentially inpatient care and specialists, and it's creating a care model that focuses on improving the health of the community with partnerships. And so really reverse engineering what we think of as payment models that focus on decreasing total cost of care, and that there's some innovative care models that can happen if we leverage the assets that are in those communities, like paramedicine, working with community health workers and expanding scopes of practice, the idea around mobile clinic, just some really innovative care models, and thinking about how do we help subsidize and incent that innovation and care delivery. The other thing that, again, then relates to that is we heard over and over that the current focus on quality measurement, and particularly that total cost of care, is problematic, and that our quality measurement and programs need to incent process measures like access to care. And that there's a real opportunity around protecting human capital and creating a sustainable workforce. And Chinny asked a great question of our most recent panel around how to create that interprofessional, interdisciplinary workforce. And I think there's a real opportunity for us to continue to, as we move to our experts panels tomorrow, to understand a little bit better what that workforce strategy might look like. And then the last thing I'll comment on is I was also struck by the differentiation within the definition of rural versus frontier, and that those are very different archetypes, and they are different care models and require different incentive payment models.
Right. Jim.
Yeah, I think there was some discovery around the definition of rural from a time and distance. I thought that was very, very helpful. I also got a sense that there was a little bit of a disconnect between what these brave, courageous, tenacious people are doing out in the rural area, caring for people, and the disconnect between the social contract that has been struck with them about how the nation is going to support them in accomplishing their goals. So that leads me to this kind of, I had this just, I was telling Jen, it's like this kind of wash over me moment where like these people, without question, that spoke with us today were sounding an alarm that it's been a while since I heard that alarm. In a way that made me think that there is a perceived domestic threat to the core infrastructure, the core fabric of our country, and we're here listening to that. We're on the front line. We're in the committee. We're in the room when it happened, to take a line out of Hamilton. And so you think a little bit like there's a population health race, kind of like analogous to a space race, that there's a threat, it's domestic, there's an infrastructure thing. We've got our SMEs are telling us that, they're ringing the alarm. And so we as a committee could certainly be forthright in communicating that in writing in our report to the Secretary. I was struck by this idea, and I think, Walter, you brought it up, this idea of there's a social contract, but there's also social accountability. There's a need for, if we make a contract from the government to the provider or communities, that there needs to be accountability back. And I think you hit the nail on the head with that. Jackson Griggs and I have talked a couple of times, and the interdisciplinary primary care team just makes kind of like the most sense as far as what key factor, this is what Dr. Fowler asked, what key factors should be financially included to increase participation? Interdisciplinary primary care teams funding, that would be kind of like, so you start to address intrinsic motivation of human beings, and particularly providers, instead of just thinking about it through the lens of extrinsic motivation, which is always thought of as money, as like, I just need for you to pay me a higher salary. When in reality, I think what I heard from a number of the speakers was, no, what we really need are the tools to do our job so that we can be successful and fulfilled as human beings. I think there was a big comment about changing the measures, period. And I think Liz asked that question too. What to measure? We didn't talk too much about how to measure it, but we did talk about what to measure, which is, and I think you bring this up, Jen, which is, measure in how much integration are you getting done? How are the patients responding? What's the burnout rate? Tell me what your net promoter score is from your provider network, let alone your patients. How are you doing on transformation of increasing access to care? And I think the labor retention issue is enormous and should be rewarded for those organizations that find a path to that. Finally, and I'll stop because I could go on and on. I was struck by this idea that the thing that they were describing that was necessary to do this work well would be the requirement of multiple agencies or departments within the federal government stacking their investments and focusing on communities that are disproportionately being affected by increased morbidity and mortality by virtue of whatever those elements are. You know, just infrastructure, history, culture, lack of a cool place to live. The weather's bad, who knows? But I think this idea that it's going to take a concerted leader somewhere to pull together the entire federal government's assets that affect health. And examples that I wrote down were, you know, the education department, the labor department, USDA, transportation department, economic development. And we could just go on and on and on. But all of those entities have funding and have missions that are health related, even though they're targeted and siloed inside their specific areas. So I think there's something to be said about this agency level action plan that at Health and Human Services that basically tries to incorporate the assets that could be brought to bear for solving some of these rural problems.
Great summary, Larry.
Well, we heard a lot. We heard over and over and over again that primary care is underfunded. There's no question about that. But I felt like I was listening to a climate change conference. And I'm listening to the people who are passionately screaming at the top of their lungs, we've got a problem here, guys. Why is nothing being done? And at the same time, the temperature's getting hotter and the hurricanes are getting worse and everything, and nothing's getting done. And so leadership can't exist in a vacuum. Something will fill it up. And I feel like after listening to this, we are leading from behind, from far behind. And we already got Medicare Advantage taking over 50% of Medicare. And as was said, there's 300 plans, and the poor primary care doc is sitting there getting beat up by each and every one of them. And how about the patients? They don't know what to pick or what to do. We don't need payment reform. What I heard was we need practice transformation. We need a model. We need to define what is the model of care that should be followed. Before you can figure out what you're going to pay for, you got to figure out what you should have. And so we heard socialist statements, and I think they're totally appropriate. If you're compensating an academic medical center 250% of RBRVS, and you're paying a primary care doctor RBRVS, maybe there's an obligation to those from those centers that they should be doing something to make sure care is being provided. Why do we have specialists making $1 million a year to take care of healthy patients and do elective procedures, and you have primary care doctors that are taking care of ill patients for a tenth of that? It just, to me, I'm struck with the gravity of this situation, the fact that CMS is leading from behind and leadership is in a vacuum right now, and we do need a moonshot. I think Jim's right. We need a moonshot. We need to make CMS needs to take some drastic measures to change this. And we can't just have a 10-year plan. By the time those 10 years go by, Medicare Advantage will be 90% of the population.
All right, thank you, Larry. Walter?
I'll keep my comments short. I think probably one of the biggest takeaways for me from today's sessions has been the fact that value-based care as currently conceived in the United States does not work in rural settings, and I think that was I kind of knew that, but I think there were actually the problems run much deeper than I had understood. You know, problems around attribution, around lack of infrastructure, around benchmarks, this whole concept of the rural glitch that was spoken about. You know, I think you know, how do you attribute patients to a PCP when there aren't PCPs taking care of patients often? There aren't primary care physicians taking care of patients because their care is being directed by advanced practice providers. You know, so I think that was a kind of a big aha. I'll just end with saying that after today's session, I feel like our task as PTAC in our report to the Secretary will hopefully address redesigning or developing payment models to support innovation in team-based care delivery models tailored to rural healthcare. You know, this whole idea that Larry just mentioned about, you know, how do you pay for something where you really don't know what the care delivery model looks like, I think resonates with me. And I think we have to figure that out, but we also have to figure out the payment models that can support the development of these team-based multidisciplinary models.
Perfect. Thank you. Lindsay.
Yeah, lots of good points already shared. I think maybe the thing I'll add is, you know, we've heard in previous conversations in this group and other listening sessions touch on the challenges that that physicians and groups have in reporting on a variety of quality and performance measures. And, you know, I think that seems to be magnified even more in rural areas. I think some of the costs we see in all places just around the variety of payers and masters people have in reporting to get payment, whether in value-based care arrangements or otherwise. And our rural areas are the least positioned in terms of data, resources to throw at the problem, et cetera. So hearing some of the conversations about attribution and how do you think about, you know, aggregating is one way to do it, but would rural areas be a place to see, you know, these all payer interventions so that you overcome some of those requirements of small ends and attribution? And could this be a way to solve problems that all communities are facing with some of these, but ease that burden on rural communities first? So I think as we think about what flexibilities do rural providers need to motivate participation, you know, we heard things suggested like decreasing telehealth restrictions, meaningful use cited as some of the things that were barriers to EMR selections, the ability to exclude outliers, and where can you get infrastructure investments. But it doesn't seem like focusing just on the Medicare population, much less Medicare Advantage, is going to be enough. I think some of the interventions in payment are going to have to cross payers to enable rural participation. There's only so much investment that'll overcome it otherwise. So I think I'll end there because I think the other big themes around primary care infrastructure were emphasized multiple times already.
Perfect. Thank you. Ginny.
Wow, what a day, right? So there's a bunch of things that I feel came out and are just so important. So the first is that people articulated there are different archetypes of rural. And I think we should really think about that. You know, if you look at the RUC codes, you know, is there a way to subsegregate those codes into different archetypes and have different solutions for each one of those that is a part of a policy? And so I think that's important. The second thing we heard is that they don't have a lot of money and they need more money. Very simple, right? So prospective payment attached to potentially different things. But one of the things that they screamed was that they needed tools. And so, you know, I think back to some of the things that have happened in healthcare that we have used to transform, Jen brought up some of the meaningful use stuff and the conversion to EMR. Those were retrospective payments, but what about prospective payments in order to be able to pay for tools and have those payments go for tools, right? So that's what I heard. The third was really around attribution and how attribution is just negatively impacted in rural areas because of population density. And so thinking about maybe within those archetypes, how do we think about attribution to a larger pool of patients and get better balancing of risk and it's maybe a longer glide path so people have upside only for a longer period of time while they build that infrastructure. The fourth thing I heard was about access and specialty integration, not having access and not having specialists. This ties to the fifth thing I heard, which was urban and rural. And, I practiced for a long time in suburban Chicago. And, being part of the academy there, we had a lot of academy representatives on our board and whatnot that were from downstate. So I got a front row seat to downstate Illinois and Springfield and surrounding, areas. And I always thought if you brought the best of what Chicago had, the academic centers, the multi-specialty groups, and they took some responsibility, accountability in return for some of their value-based care, or you pulled those to suburban areas or to those rural areas, Hattiesburg and some of these places where some of my colleagues came from. And I heard that today. Between urban and rural. So I think that's really an important thing that could enable practice transformation. Another thing that one of our colleagues said here. So, a lot of really good things. I'm optimistic that we've done enough things in healthcare that have moved the needle, that if you go back and look at history, you can craft a future here, taking little tidbits of lessons we've learned. The primary care medical home model might work really well in one of these archetypes, right? So I'm optimistic. And then the last thing I'll say is, I do feel that we need to probably highlight this disproportionately, even though 15% of people live in rural areas. Medically underserved areas and rural areas they're a large swath of this country. They produce a lot of our resources, like they said, but they also are the underpinnings of some of our geopolitical polarization and instability. And so I think, health is humanity, and therefore people not having access to health care, it is a huge thing for people. And so if we don't solve for this, I think we continue to have a country of haves and have-nots and thems and us's, and that's a problem.
Appreciate that, Jenny. I took several themes from all of this, and at times I hearken back to something that we've said at a prior meeting, which was we really need to think carefully about how to make it increasingly uncomfortable to practice in fee-for-service medicine. But then I really got in touch with that the flip side of that is we must also simultaneously make it increasingly comfortable to practice in value-based practice. And we heard our rural colleagues saying that's not happening. All they're getting is it's impossible to practice in any economic situation almost. So I was struck that there were some themes that came out of this, which is for our rural practice brethren and population, it's critical factors are unified definitions. I'm struck that there's just CMS programs uses at least 3 different definition sets of race, language, ethnicity data. That's impossible for payers and big practices to manage, much less small rural practices. And that's something that with policy internal Medicare could take a lead on. A standard defined metric set. I mean, there's 2,500 measures. I don't know that we need to make up more measures. We need to use the measures we have now better and in a unified fashion. At almost every faucet, we hear a plea for multi-payer involvement, and I represent, a payer, work for a payer that's involved in both Medicare Advantage and exchange and commercial space, and we're happy to participate, but I think it is going to take some policy and federal leadership to lead the way and put enough carrot and stick involved that private payers who are often as big as the agencies making the carrots and sticks decide they want to participate. Usually your provider affiliated or provider owned payers are always willing to go with the unified community measure set. It serves everybody's needs. And then a plea for data. There just needs to be more assistance. And if there's a moonshot anywhere, it's a moonshot around this health data ecology that's the power utility for the healthcare system that we keep hearing picked up in different strains at almost every meeting. So I was struck with that. And then I've got 4 pages of comments, but just some comments I'll pull out. I was struck certainly by a rural payment structure issue that a large portion of rural care is provided by rural health clinics, FQHCs, and critical access hospitals. And their payment structures are such that they almost never match up and let them participate in any of the innovations that have happened in the last 20 years. And past that, not only is it hard to explain to your board of directors how your cost plus reimbursement is going to marry up against this, and they never fit together, and so you just never really get a light to go forward. Most or many CMMI models exclude all of those rural healthcare facilities. So essentially, we've lost 20 years of innovation that have been happening in other markets, which is really a dearth of, I think, knowledge that we need to figure out how to close. I was struck by some rural definition issues that have been previously mentioned, especially this difference between rural and frontier. Can't paint with a wide brush. They're very, very different with the same types of needs, but an order of magnitude difference in severity, being 40 miles from a large urban area versus truly ultra rural. I thought there were some really good comments about, and I'm intimately familiar with Medicare's approach to an exchange approach to access defined as time and distance from the practice, but yet it's actually not the time and distance from the practice that make network adequacy. It's actually the amount of resources available to that practice. And so this concept that time and distance of certain key assets in care of a population, whether that's what was mentioned was OB and cardiovascular and oncology services, and those are really smart, as those are 3 of the top 5 cost buckets for our population. So I thought that was interesting. And then similar to this idea of using Medicare's policy leadership to just streamline functional definitions of things like race, language, ethnicity, there's different definitions of rural across different programs. And so what makes you rural and qualify for one program may not qualify for a different rural program. It seems like there's no perfect definition, but we're all served by just picking one and going with it at some point in time. And then lastly, there were 2 metric things that I pulled out. One is this idea of this rural glitch. And my data geek is saying that would just infuriate me, that if I was a rural provider and my data set is being used to measure my delta versus the community, but my practice is 72% of the community, I'm competing against myself, can never show meaningful change. Somehow that's got to be fixed. And that's, again, within policy leadership to figure out how to do that. And then the last piece I'll bring out and then turn it back to the chair is this guidance over the reality that you've got a population in a pilot, 2 outliers. You've got, one mom who's in a car wreck and delivers a 26-year-old preemie, and your measures are just destroyed for the year and there's no recovery. There's got to be a way to exclude outlier white swan events in a measure set. And that the science is there. We should be able to figure that out and put that into practice. So that's what I pulled out from today. Thank you.
Thank you.
Excellent comments. I'll just add a couple of layers. Whether you're looking through the lens of Medicare, Medicaid, commercial insurance, social determinants of health, health equity, there's a crying need for coordination and integration into one ecosystem in rural communities. We heard great examples of a hub and spoke model connected to an FQHC, hospitals operating as conveners and connectors and utilizing the diverse resources to really pull people together. but the need to share services and really look at what is a best practice connected ecosystem heading towards health was really an interesting theme today. A couple other things I heard, a few very specific policy recommendations that I thought were interesting. So removing the face-to-face requirement for telehealth, waiving the one visit, one service for FQ billing, and also increasing access to hospital at home, as well as looking at the ability for attribution to advanced practice providers or eliminating the physician as a pre-step in rural health were all interesting policy recommendations. A lot of rich dialogue, and really looking forward to what else we bring out tomorrow.
Perfect. So thank you all. So I'm just going to have a couple of closing comments, and I really want to emphasize what Chini and Jay said from my experience. Spent most of my career in a large system that had two separate large academic medical centers, each one of them surrounded by rural health for miles around, serving 1.2 million patients. And I can tell you that even though those rural areas may have only had 15% of the population we're talking about, that 15%, if they did not have those rural hospitals and had to move to those more tertiary health centers for care, those tertiary health centers would have collapsed. They cannot. In fact, we spent most of our time trying to figure out how do we unload the academic health centers and move those out to the rural health centers for more primary care kinds of issues, because the ER was always backed up, the hospital was full, the tertiary patients couldn't get into the tertiary referral centers because of that. 15% is a lot of patients. And so I think this warrants more attention than a 15% number might come across as. This is a major national problem. And so just want to emphasize the importance of this discussion. So thank you all. It's been a great day today, kind of overwhelming amount of information, but very good. So any other comments from the committee members or otherwise before we adjourn?
I forgot to say, this could be budget neutral. This doesn't mean we have to have new taxes, new spending. Right. This could be budget neutral if the model is what you're paying for and you restructure how people are getting paid.
Yep, I agree. Good. Well, thank you all. We'll re-adjourn tomorrow.
Produced by the U.S. Department of Health and Human Services.